Hello and welcome to the 2012 San Antonio Breast Cancer Symposium. My name is Skip Burris and I'm from the Sarah Cannon Research Institute in Nashville, Tennessee. I'd like to introduce you to Bill Gradishar from Northwestern and Hope Rugo from the University of California, San Francisco, and we'd like to discuss with you some of the highlights from the meeting here in San Antonio. Maybe we could start with talking about some of the data that's come out of the hormonal trials. Hope we've had presentations on the Atlas and the Confirm trials, two studies that have looked at Tamoxifen and Fulvestrant in very different settings. Maybe your thoughts on the Confirm trial for starters?
Well, it was nice to see the updated results of the Confirm trial in the abstract, and I think, you know, as we've incorporated using 500 milligrams of fulvestrant into our practices, we really stopped using 250 milligrams. It was nice to see the longer-term follow-up documenting the survival benefit, which, you know, is an elusive target in hormone receptor-positive disease. So I think quite confirmatory for us in the Confirm trial. And the side effect profile also really didn't seem to be much greater, except for in the US they get 2 injections. So I think the implications for this are also about the combination data that we saw recently from the SWOG study looking at combining fulvestrant and anastrozole, but that was the 250 milligram dose, and they saw a benefit in survival. It may be that you get the same thing from just using higher dose fulvestrant.
Bill, any additional comments to think about with the fulvestrant data?
No, I think it reaffirms our thought that we have a dose that should be used now. I think that we have safety data that confirms that giving a bigger dose isn't intolerable to patients, and it seems to be translating into an advantage in outcomes. So I don't think there would be any quibbling about how we should administer it at this point.
It feels like we're starting to see more of the targeted therapies being brought into clinical trials with fulvestrant, and the data here certainly seems to support that it's a viable agent, often sort of thought of after an aromatase inhibitor, at least in the United States. Hope, when do you decide to use fulvestrant in your practice?
Well, I was very interested talking to John Robertson from the first trial that, you know, they can't use fulvestrant first line because it's not approved in that setting in the UK. But occasionally in a patient who's progressed on an AI from adjuvant and becomes metastatic will use fulvestrant in that setting. Also, of course, the targeted agents are coming in earlier. But what was most impressive to me when the first data from the Confirm trial came out is we would treat patients who hadn't had any real response to fulvestrant at 250 milligrams, and then they would respond to 500 for months and months. So I think regardless of where we use the agent, it's clearly got much better efficacy at this dose. And it depends on what trial you're enrolling a patient in, whether they want to take a pill or get an injection. I mean, one downside for patients is coming in for the injection every month as opposed to potentially going away for 3 months on their pill. So,
good,
how about
good.
you? Where do you?
Yeah, no, I think that you're right. I actually have found myself using it more commonly now that I think we feel good about the dose. There is some attractiveness to getting that part of the therapy out of the way with an injection. And when I'm looking at some of the trials now where we're giving a PI3K inhibitor or an mTOR inhibitor in combination with hormonal therapy, nice to just be taking that one pill during the day and not interfering with 2 drugs. But I think that fulvestrant's probably got a different role in breast cancer than it's been given credit for through the years. And nice to see that we're feeling better about the dose. Yeah. Another drug that sort of an older generation, not thought of as much in the initial setting of adjuvant therapy, is tamoxifen. And we've got some results from the Atlas trial, a study that looked at comparing 10 and 5 years. Bill, your thoughts on the Atlas trial and whether it has any relevance to the practice of breast cancer today?
Well, the Atlas trial is interesting because we've talked about this trial for years, and there was another companion trial that also sort of looked at a similar question, which was really longer durations of tamoxifen. And if we go back sort of in history a little bit, we know that based on data from the NSABP, we elected, you know, some time ago to say that 5 years was the standard of care, but there was still this sort of open question whether longer durations might be better, particularly because we tend to see late recurrences in patients with hormone receptor positive disease. Obviously, the world has changed a bit. We use aromatase inhibitors more commonly. We use tamoxifen perhaps in sequence with an AI, but the Atlas study that was updated suggests that longer durations, 10 versus 5 years, might confer additional benefit in terms of reducing the risk of the disease coming back. And there are all kinds of caveats to this, of course, because the original report, we knew that probably at least a third of patients in the study, we didn't know the hormone receptor status. There's always a question of compliance, not at 1 or 2 years, but can you imagine at 8, 9, and 10 years, how many patients are actually taking the drug? But in their model where they partnered the ATLAS trial with the overview analysis and sort of make a theoretical model, the longer durations seem to translate possibly into improved outcome in terms of reduced risk of recurrence. So I think we'll have to sort of digest this. I don't know that it's going to alter how we approach patients, but it does give some hint that particularly if you can't tolerate an AI or an AI is not appropriate, perhaps there are some patients where longer durations of tamoxifen might be appropriate.
Hope your reaction to the story and put that together with how commonly do you give 10 versus 5 years of hormonal therapy in general in your practice?
Well, I think there's a group of patients for whom this really makes a difference, this data, and it is unfortunate that much of the results are obtained by modeling, not anything against modeling, but as was mentioned already by Bill, I think the compliance issue is really a big deal in these studies and understanding, which biology the tumors were. But nonetheless, there were less recurrences in patients who took tamoxifen for longer. And actually, that's not so dissimilar from the NSABP data. There were less recurrences. It's just that in that population that was older, there were other problems. People were dying of other medical illnesses. So if we were screening patients relatively carefully for thrombotic risk and other problems, and maybe not treating our 75-year-olds, then the premenopausal women who reach 5 years and they're at high risk, they had multi-node positive disease, if they're okay at 5 years, by definition, they have hormone-sensitive disease. And then you could extend hormone therapy in that group of patients. So having already seen the previous data from this trial, I have sometimes extended out tamoxifen to 7 or 8 years. I have to say I've never gone to 10 years. Seems like a really long time. But in a postmenopausal woman, I'll switch to an AI because the data from the Canadian trial, I think, is just much more robust. But in younger patients where we don't have that option, I certainly am not suppressing the ovaries at 5 years in order to be able to give those patients an AI, which occasionally I'll see in patients who come for other opinions.